and I'm joined today with Dr. Amir, our geriatrician, and her nurse practitioner, Janelle. Welcome, welcome. So happy to have you here today. We are talking about senior health and when to see a geriatrician. Today on the agenda, we're going to discuss what a geriatrician is, the illnesses and diseases that they treat. We're going to touch a little bit about Dr. Amir's treatment practice for osteoporosis. So I want to dive right in with the first question. What is a geriatrician, and what is the difference between a geriatrician and a primary care physician?
Okay. Welcome everyone. Excited to have this opportunity, and always happy to talk about geriatric medicine and geriatrics in general. So the big difference between geriatric medicine and primary care is that geriatricians are trained specifically in looking after older adults. Traditionally, the cutoff is 65, but as we have an aging population, there are roughly 20,000 older adults turning 65 every day. And we only have 7,000 board certified geriatricians in the United States. So you can imagine that there's a definite shortage. So the definition of when to see a geriatrician is slowly changing. I'll touch on that. The goal in geriatric medicine is to care for the older adult and try to maintain function. So there are syndromes that come up in older adults that are part of aging that we try to manage. Those symptoms can masquerade as other medical problems, and we are trained to spot the difference between a true medical issue and a symptom that's resulted because of aging. Our primary care colleagues do an excellent job of preventing disease. That's their primary function. So we do work hand in hand with a lot of our primary care providers. Our clinic in Bayonne, we have a primary care division, and we have us as the geriatric medicine division. So they do refer patients to us who have specific geriatric issues. We come up with recommendations, and then we send them back to their primary with those recommendations so that they can implement our suggestions. And we usually have them follow up in a couple of months to see how they're doing and see if we need to tweak any of those recommendations or change anything. So it is a specialized area. The term geriatrics was coined in 1909 in Germany, and it's slowly spread around the world. Geriatric medicine has been recognized as a board specialty since I think the 1990s. So about 30 years old. So a relatively young discipline for older adults, and it does require attention to detail to figure out what is what. So I hope I answered the question on what a geriatrician is and how we're different from primary care.
Yeah, absolutely. That was a fantastic answer. Thank you for a little bit of the history as well. So it sounds like, and correct me if I'm wrong, that you would see a geriatrician in tandem with your primary care physician. So not to replace your primary care, but like you would see a specialist.
Radiologist, rheumatologist.
Yes,
Yep.
any of those. Okay.
Yes. So I will also clarify that you could see a primary who is also a geriatrician.
Okay.
We have a small group of patients who are primary to us, in that they see us for all their primary care needs. But I'll be honest, they're all above 90, and they have very, very specific healthcare needs that are better served by seeing us. And we're, given their advanced age, we're trying to minimize the need for them to go to multiple providers and just streamline their care. So it is possible to see a geriatrician as primary, but
Mhm.
they're usually reserved for the most complex, frail older adults.
Okay. And I know you had mentioned as well, and it touches a little bit on my next question, that the sort of age number, like that go-to number for like, oh, it's my blank birthday, it's time to see a geriatrician, sort of shifts and changes. There a range, or is there perhaps like a medical issue that sort of would signal to you or your primary care physician that it's time to now incorporate a geriatrician into your healthcare plan?
Right. So, from the general public's perspective, it's helpful to have a number cutoff. So
Mhm.
65 is the current cutoff.
Okay.
That's also the cutoff with Medicare. So, so we're all saying the same thing.
Hmm.
Um, recommendation is for patients above 65 and above to have an annual wellness visit with their primary care providers. That visit is designed to screen for the common problems that geriatricians deal with. And if we pick up something during the screening, um, the primary care provider can refer to us. There are patients who come in to see us on their own, and that is not based on an age cutoff. That's usually based on a concern that they have,
Hmm.
and some of the common concerns are, issues related to memory, being on too many medications, being, falling, um, some struggling with loneliness, isolation, especially as we've been seeing a lot more of that with the pandemic.
Hmm.
Um, Issues with incontinence, urinary incontinence. Orthostatic hypotension. Those are some of the things that we have patients coming in for independently of being referred by their primary care doctor. Usually, events like this or talks like this
Hmm.
increase awareness. So we've had a lot of, family members, sometimes sisters, daughters, sons, who attend these kind of talks and then look at their loved ones and think, well, maybe they would benefit from an assessment. And I always say there's no harm to being seen. If we see you and we think you're probably doing well, we would tell you that. And because we're trying to maintain function, we tweak a few things here and there and have you come back in a couple of months or a year, and that's a good thing.
Hmm.
It's just getting a different perspective on your health needs and health issues.
Absolutely. Janelle, is there anything else you wanted to add to this? I know Dr. Amir is doing a really great job covering all of the topics, but I wanted to see if you had anything to
Yeah.
add.
I just wanted to add that you may also see me in the clinic as well. So geriatricians do work very closely with a lot of other team members, including nurse practitioners. So you may see me in the clinic as well. I am a board certified geriatric nurse practitioner. So I'm certified both in my nursing background and as a nurse practitioner as well. And we really do want to focus on what it is that matters most to our older adult patients, and really tailoring that care to individualize it to meet their needs the best. So that's all I really wanted to add, and that you may see me.
That's wonderful. And it's wonderful that you have like this team approach to this sort of care. I think that's important to highlight as well, because you had mentioned, loneliness and concerns with the pandemic. So I think it's important that, you're not facing, no matter what the age, you're never facing something by yourself. I know you touched on a few of the common illnesses and diseases that people sometimes come in on their own for. Is there any you'd like to add to that list? Diseases or illnesses that geriatricians specifically are looking to treat?
So I think a good way of breaking down the illnesses is how we approach. there has been a big push over the past few years to have a more age-friendly approach to older adults, and that may not be one disease or one symptom. Rarely do patients come in with just one problem. It's usually a number of things. And sometimes the question is, do we need to fix this, or do we just need to figure out how we can live with this, live a better life with this problem? Because we don't want to go for surgeries, or we don't want certain interventions or certain treatments. So as Janelle mentioned, we really look at what matters most, and that comes from the 4 M's, which are an initiative from the Institute of Healthcare Improvement. So what matters? So the matters is one. Mentation is another one, and that falls. So dementia falls under that. We deal with dementia related to aging. So Alzheimer's, dementias. There are a lot of other types of dementia as well. We get referrals from neurologists when dementia has advanced beyond a point that there really is any treatment. And so we focus on helping with the behavioral issues. We connect families to available resources. We can make recommendations on, how much help you need at home, when it's maybe time to consider, moving into a facility. And, there's a number of medications that we can try before making those recommendations. So that was the second M. The third M is medications. So, as we age, the way our bodies metabolize medications changes. Sometimes we have patients who have been on the same medications for 20 years, but now because the way their kidneys are working, the way their liver is working, those drugs linger in the system a little bit longer than they did, 10 years ago or 20 years ago. And so we start seeing more adverse effect of medications. So it is good to review, and it is good to have someone who will ask questions about each medication and almost challenge whether you still need to be on them or not. Too often we see patients who are taking medications for conditions that have resolved, that are no longer an issue. And they're presenting with complications and side effects of being over-medicated. And we see that with blood pressure medications. We see that with thyroid medications, diabetes medications. The guidelines are a little bit different for older adults, in that, where we don't have to worry as much about the numbers. We can focus a little bit more on the patient as a whole. So how they're doing overall. So, to give you an example, the recommendation for blood pressure in patients with heart disease is less than 120/80. And those are specific recommendations. If I have an older adult with blood pressure that is that tightly controlled, but is falling every other day and is fracturing bones and is injured, I would definitely say that this tight control, even though we have good numbers, this tight control is not helping the patient. So with the experience and with our literature, we can liberalize that blood pressure and potentially improve the quality of life, allowing the patient to do really what matters. So tying back in, and the last M is mobility. So being able to ambulate, being able to safely make it from one place to the other. There's a lot we can do to help, assess gait. We know when to refer to physical therapy. We can make recommendations for physical therapy at home, what to target, what to focus on, whether you need a gait assistive device. whether we need to do any more testing to figure out, what's going on, if there's a gait issue. And, if we are able to evaluate gait speed, we can give you information about frailty as well. And frailty is one of the core syndromes of geriatrics. So, as we age, we see that older adults lose muscle, and that makes them a little weaker. If we catch it early enough, we can try to implement exercises and improve nutrition and try to reverse this. I'm not saying we have a cure for aging, or we're able to reverse aging, but it's all about improving quality of life and really enjoying the time that we have. There was an article I was reading that I think said it quite well. It's about how you live your life. It's not about waiting to die. So, we really want our patients to be able to enjoy and in whatever way that is important to them. Be it, whether they want to be able to attend concerts with their loved ones, be able to sit on the porch with a cup of coffee, do some gardening, travel around. We really want to try and tailor our recommendations so that they can achieve what it is that they're trying to.
It sounds like, too, from a planning perspective, that once you sort of like approach that 65 or older age, it's really good, like you kept saying, from a planning perspective. So for individuals planning, it's really good to sort of loop you guys in to different types of care, where you are currently, like we'll just use 65 as that number, in terms of like what illnesses you might have or things you might be working on. That way you can sort of try to make that long-term plan, and you can have that really good quality of life in your older years. I know everyone wants to have a nice retirement, and I think being healthy definitely goes hand in hand with that. Janelle, did you have anything you wanted to add about kind of common diseases and treatments from a geriatrician perspective?
So I noticed there was
a question in the chat box, I think directly related to what Dr. Amir was talking about. It's from Angeline Rodriguez, and she says that her concern is medications prescribed for high blood pressure in particular being overdosed, and that most doctors tend to use a one-size-fits-all approach rather than customizing meds to minimize the side effects, which is, really when you come to us, we want to use a patient-centered and family-focused approach, tailoring what matters most to you. So certainly medications for blood pressure is something that we really closely look at, and it's, if it's making you feel dizzy or if it's giving you any side effects that you're feeling, is too tightly controlled, that is certainly something we can focus on in the clinic with you, and we can take a very close look at medications specific to blood pressure. What we tend to see is that sometimes the blood pressure is over-controlled and that we may have multiple medications prescribed for treating blood pressure. So that is certainly something we can address in the clinic and tailoring what it is that matters most to you. We can also offer education for family members in caring for, say, patients with dementia or may have the behavioral changes associated with dementia. And these could be like very simple interventions that don't involve medications at all. For example, how can we help with sleeping and promoting a regular sleep-wake cycle? How can we promote more socialization around mealtime to perhaps increase the patient's appetite? We recommend, simple interventions such as promoting finger foods instead of using utensils. Something as simple as that, that's certainly something we can help tailor for patients and families dealing with challenging times, such as caring for a patient with dementia. So certainly we want to be able to make the plan of care to match what it is that you are looking to achieve and what your goal is for both short-term and long-term.
Excellent. Yeah. Again, I really just love this, that you guys keep using the same phrase, like this planning approach, because I do think that at least I'm a little bit on the younger side, got a few years before I have to see a geriatrician. It's not something that you're necessarily thinking about before you sort of hit that 60, 65 age. So I think it's really great that we're talking about it today. And just even just letting it ruminate with some of perhaps our younger audience members who might not have to see you guys for another 10, 20, 30 years. It's just good to be familiar with what you guys do. Before we end it today, I know, Dr. Mir, that you have a treatment practice that focuses on osteoporosis, and I was hoping you could just tell us a little bit about that and its impact on the community and patient outcomes, because I know osteoporosis is you see commercials for it all the time, and it's sort of one of those hot words that goes hand in hand with aging diseases.
Yes, I wanted to add to what Janelle was saying about our approach in the clinic. We are fortunate in that we have a little bit more time allowed for our older adults. So, for a new visit, we allocate at least an hour, and for follow-up visits, it's 30 minutes, which is much more time than you would have with your primary care doctor. So, we have more time to kind of go over all the problems, get to really know the patient and, what their goals are, and then tailor our approach. The osteoporosis clinic that we run, we started this initiative about 6 months ago. It's in partnership with our rheumatology department and our physical therapy department. We were seeing a lot of patients in the hospital coming in with falls and fracturing various bones. It is not normal for an older adult to fall from standing height and fracture a bone. Traditionally, you would expect much more force needed. And so the missing piece is that the bones are potentially weaker because of underlying osteoporosis. So we got together and we said we can try to treat this osteoporosis, but just treating the bones isn't maybe the best way to approach it. There's a lot of literature out there about co-management. And co-management with a lot of subspecialties. I mean, in the hospital, we co-manage with surgical patients, with orthopedics, with the intensive care unit sometimes. So we agreed to co-manage with rheumatology and physical therapy. So what happens on the third Tuesday of every month is we have patients that have been referred. They can be referred by your primary care doctor or by us if we've seen you in the hospital and think you would benefit. So when you're referred to this clinic, you will be seen by a rheumatologist who specializes in osteoporosis management. You'll be seen by a geriatrician who will take a holistic approach, kind of do a geriatric assessment to see what risk factors you have for falls, be it medications, be it orthostasis, be it memory issues, gait issues, and then if needed, we refer to physical therapy as well. So it's an all-stop shop. You can see everybody in the same visit. So it saves multiple trips to different clinics at different times. It does take a while, so we usually tell patients to be prepared for that. Because it's a relatively new initiative, we don't have all the data from our work, but we know from literature and from similar programs in other states that because osteoporosis is so prevalent and underdiagnosed, there's a lot of room to treat and prevent the long-term adverse outcomes of untreated osteoporosis, which we see in older adults who fall and then end up with fractures, and then they're not able to be as independent as they were before. And so we're always trying to get a little bit ahead of the curve with regards to managing osteoporosis.
Janelle, did you want to add anything? I know we have a couple questions popping in on the chat, and before we switch it over to the Q&A, if there's anyone else who wants to add questions to the chat, but Janelle, if you have anything to add about the treatment center.
No, nothing to add. I was just reading all the chats coming in, excited to see some people in the clinic. Referrals for behavioral therapy to address stress, et cetera, for seniors, that's certainly something that we can look into and recommend if we see that we feel that it's needed. Again, we do try to address, as many angles as possible during our visits. And Dr. Amir was saying, be prepared for a longer visit than your usual primary care visit. So we were joking around, but bring a snack. Yeah, just be prepared. We do dive deep into, as many angles as we can get into to better help our patients from all aspects. And the second question, this sounds fantastic. How can I sign up? I have osteopenia and want to do as much as possible to stop this from getting worse. So I think we're going to have our information for consults. Can we put that in the chat here?
Yeah. Can you type it real quick, or do you want me to grab it from online and I can put it in?
So for osteopenia, I would recommend starting with calcium and vitamin D, and then come and see us. So the recommended calcium is about 1,000 milligrams per day, and the vitamin D is 800 international units once daily. You can also sit out in the sun for vitamin D if you don't want to take any more pills. And calcium can be taken through dietary means, so dairy products. If you don't consume dairy, 2 cups of almond milk has roughly the recommended daily amount of calcium that you need. So there are many ways to start preventing, but of course we're happy to see you and do go more in depth and come up with more recommendations. I know there was a question about GYN issues in older women. I just wanted to touch on that because someone had emailed that question in. So the issues that we see most commonly are more urogynecological issues because the bulk of our patients are postmenopausal. We've passed all the hormonal issues, all the childbearing issues, and so we're more in the realm of lower hormone levels, so lower estrogen, and lower estrogen can cause the urothelial mucosa to be thinner, and so more likely to break down, and that increases the risk for urinary tract infections. So we see a lot of older women coming in with recurrent urinary tract infections, and we can try a number of things to help manage, besides antibiotics, to try and manage those symptoms. Usually we start with a physical exam in the clinic, and then based on what we find, we would refer accordingly. Things like organ prolapse, things like weakness of the pelvic floor. We can refer either to physical therapy for pelvic floor exercises, or if there is organ prolapse, then we would recommend evaluation for surgery or for a pessary. So it would really depend on what we find on exam.
Thank you. I believe Janelle popped in your office information in the chat, and someone had asked about a transcript. We will be posting this later on RWJBarnabas Health Medical Group's Facebook and LinkedIn pages, and you can view it again later. You could share it with family and friends from there. We will also put their office information with the video on Facebook and LinkedIn, so you can grab that there. But it's in the chat right now if you want to jot down a telephone number or an address. Thank you both for chatting with me so much today. Is there any final thoughts before we sign off from our senior health and geriatrician care?
I just wanted to add, to kind of tie it all together and to round it out, that at Jersey City Medical Center, we do train our healthcare team to address the specific needs of our older adult patients. So in the event that you do need hospitalization and you come to Jersey City Medical Center, both Dr. Amir and I are present here in the inpatient setting as well. We do have a program, we call it the Nurses Improving Care for Health System Elders, that we use to train our healthcare team, again, to address the very unique needs of our older adult patients. Thank you all for giving your time to hear our talk today. We were both very excited to be here.
Thank you both for joining me. I think we had one final question about encouraging a family member to see a geriatrician. I don't know if you wanted to just briefly touch on that. I know seeing doctors never gets more fun.
I know. So this is a tough one. You know, when you are bringing an older adult to see a geriatrician, it comes with the connotation that you're old. You know, you may be getting old. So it's not easy to convince them to come. I usually, you know, if we have an older adult who's resisting, try to figure out, you know, what their concern is. You know, are they afraid of being seen as old? Are they worried about maybe losing their independence? Is there something else that's concerning them? Trying to address that. Sometimes, you know, because we're also in a primary care clinic, we can almost word it as if we're going in to see a general doctor, and you know, that's partially true because we're in the same clinic. If there's a specific concern, you know, we can try to say, you know, just like we are checking your blood pressure, we want to get your memory checked, we want to get your medications reviewed, and just try to frame it in exactly what it is that we're looking for. So that it really depends on what, you know, why they're resisting and what they're worried about. Oftentimes it's worry about or fear of losing independence or fear of finding something wrong that holds the older adult back.
I think one thing too that you stressed was, you know, that something that you're always looking to do is help give people back their independence or more of their independence. So there's obviously no guarantees in healthcare, but seeing a geriatrician such as yourself or Janelle, it certainly gives you more of an opportunity to do that versus not.
Right. I mean, if you don't look for the problem, you're not going to find it. So, you know, if we look and we find everything's normal, that's great. But if we find something, there's potential to work on it. And if we don't look for it, we'll never know. So I usually do encourage older adults to be seen at least once, and then go from there.
And you're both so lovely to chat with. I think that anyone would be happy to come by and have you take a look at them and see how they're doing. But I think that was it for our questions. I think we had a few people in the audience that were just thanking you for your time, and I just want to reiterate that. Thank you so much for joining us today and chatting about senior health. As I said, their information is in the chat if anyone wants to grab it real quick before we sign off. Otherwise, this will be on the RWJBarnabas Health Medical Group's Facebook and LinkedIn pages. If not today, then sometime next week. Thank you all for joining us, and I hope everyone has a wonderful afternoon and a wonderful weekend.
Thank you.
Bye.
Bye.